Hello folks, this is David Villar, and welcome to this video in which we are going to review some general approaches to intoxications. We're going to focus mostly on small animals, but I think the main principles can also be extrapolated to large animals. And we're going to make this video interactive. There will be some pop-up questions, and I'm going to prompt you to answer them along the way. And we're going to start by situations in which poisonings can be suspected. And I guess the first one by far and away is when a healthy animal becomes acutely ill or dies suddenly. We can also look into whether some changes in the environment of the animal have taken place and there are some potential exposures to any toxicants. And how about some recent ingestions of indoor or outdoor plants? And I'm thinking of Easter lilies that are bought particularly during the Easter time, and they're brought into the house, and you have some cats living in there that are very nosy, as you probably all know. And how about some new foods or changes to a new batch of food? This kind of becomes probably more relevant in food produced in animals. How about some recent applications of lawn, garden, or home pesticides? Any unintentional exposure to drugs, or maybe the garbage can that was turned over by your dog? And finally, we can not forget about intentional or malicious poisonings that everybody has in the back of their mind many times. So one of the main basic rules of toxicology is to treat the patient and not the poison. If the patient has some clinical signs that are endangering his life, obviously the first thing that needs to be done is to provide life-saving measures to stabilize his vital signs. I think you probably all heard of ABC, airway, breathing, circulation. Once the patient is stable, we can start considering everything else that we're going to see next. Starting with attaining a complete history to determine the time of exposure, the dose ingested, and interpreting the clinical signs from the physical examination. And from here onward, we can argue whether decontamination is warranted, if there is an antidote for the specific toxicants, if we know what it is. Can we prevent the distribution of the drug or poison to the site of action? Can we enhance the elimination of the toxicant? And finally, all of these things need to be combined with providing supportive and symptomatic care, and obviously watch the patient closely. So on the next slide, we're going to elaborate on each one of these potential therapies to treat poisonings. And we're going to start by talking about decontamination. Technically, decontamination refers to preventing the absorption of the poison from the site of the exposure, which most of the times is usually going to be through ingestion. If you look at decontamination, you will see that some references also include steps like promoting the elimination of the toxicant, either by diuresis or dialysis, and also the distribution of the drugs to the site of action by intralipid therapy, which we will discuss later. So the first thing would be to consider whether we need to induce vomiting. And the decision is going to be dependent on three things. First one, the time since the exposure. Second one, the type of poison. And third one, whether the animal already presents some clinical signs. The exposure needs to be recent or relatively recent, within at least the previous 2 hours. Otherwise, it's likely that the poison may have already moved into the intestines. If there has been more than 2 hours elapsed before the presentation, maybe we should consider other measures like activated charcoal instead of inducing vomiting. And obviously the patient needs to be stable, and if it shows any clinical signs, it may not have a proper mentation and a gag reflex to protect the airways. And in those situations, maybe a gastric lavage may be more appropriate. Now, if there are CNS signs, particularly of depression, obviously the gag reflex may be compromised, and there is a greater risk of aspiration if we induce vomiting. So if you see signs like agitation, disorientation, ataxia, obtundation, dyspnea, convulsions, or the opposite, recumbency, coma, obviously those would be indications or contraindications to induce vomiting. Inducing vomiting is contraindicated also with particular poisons or toxicants, like those that may be corrosive substances. I'm thinking of bleach. You don't want to expose that esophagus twice to a substance that is corrosive. And also there are some low viscosity hydrocarbons. I'm thinking of gasoline, kerosene, torch fluids, lighter fluids. These are really prone to move into the airways. You don't want to risk the animal to have a bronchoaspiration of anything. Now, before we mention how to induce vomiting, I would like to remind that the vomiting center receives input from different areas of the body. Most centrally acting drugs work at the level of the chemoreceptor trigger zone, but we can also cause irritation of the stomach lining, and those would be obviously peripherally acting drugs. Now, if you put a cat, for example, on its carrier in a spinning or rotating chair, where would you think the stimulus would come from? I think you have probably answered that correctly. It would be from the labyrinth or the vestibular organ of the ear, and we'll talk about that, way of inducing vomiting later. Here I wanted to show you where the chemoreceptor trigger zone lies in comparison with the vomiting center. They're both located in the brainstem, and the big difference between both is that the chemoreceptor trigger zone is outside of the blood-brain barrier, whereas the vomiting center is within the blood-brain barrier. And why do I mention this? Well, there are some drugs like morphine or hydromorphone that stimulate the chemoreceptor trigger zone, but they do depress the vomiting center. When you inject them, they're going to reach the chemoreceptor trigger zone before they get to the vomiting center. And this explains why they can be used to induce vomiting. On this slide, we also see that the dogs have primarily dopaminergic receptors at the chemoreceptor trigger zone, whereas cats have mostly alpha adrenergic receptors. And that's going to make a difference in the type of centrally acting emetics in both species. So here we can see the type of drugs that can be used in both dogs and cats. As you can see, salt is contraindicated, as we will see in the next slide. The classical peripherally acting drug is hydrogen peroxide. It works by bubbling against the stomach lining, which causes local irritation, as you can imagine. Now, remember that the stomach is like a football ball. When it's empty, if you induce any contractions on those walls, they're not going to be capable of emptying whatever is inside. So if the animal has not had anything to eat recently, it may be necessary to give some soft food that can be brought up easily before we even try to induce emesis. The other drug that we see here is syrup of ipecac. It's mentioned in many old textbooks, but now it's kind of contraindicated in both dogs and cats. And the main reason is that it takes a long time before the animal vomits. It could be up to 30 to 40 minutes. If we talk about the centrally acting drugs, apomorphine is the way to go with dogs. It can be administered intravenously. And if you have a tablet, you can crush it in saline solution and apply it directly onto the eye. Now, the downside of apomorphine is that it causes prolonged, protracted nausea and vomiting far beyond the point of emptying the stomach. And in those cases, you can always reverse the action with naloxone because apomorphine is an opioid drug. The good thing is that it works much faster, within seconds of giving it IV, than any other emetic that you can use in dogs. For cats, we have two alpha adrenergic drugs, which are xylazine and dexmedetomidine. The good thing is that both have a reversal agent, which is atipamezole or yohimbine. And any of these drugs can also be combined with this other one we see here, hydromorphone. And if you want to enhance the efficacy or the success of vomiting, you can always put that cat in its carrier. Let me see if I can get this playing. There we go. You can put the cat in its carrier on a spinning chair, and as I mentioned earlier, this is going to enhance the effect of any centrally acting drug that you are administering. Okay, I said before that salt is contraindicated, and on this slide what you see is what happens in 14 dogs that ingested bread dough, which is very high in salt. And as you can see, 4 out of 14 animals had convulsions, and 2 of those died. So the take-home message is that salt is very dangerous and should not be used to induce vomiting, because basically there is a very high risk that enough sodium will be absorbed at toxic levels for the brain. Gastric lavage. This is obviously another way to decontaminate an animal if vomiting is contraindicated, and this is basically for patients that are not normal mentation-wise and may have a poor gag reflex. The downside with gastric lavage is that we need to anesthetize the animal and intubate it endotracheally to protect the airway. The way it's done is you have a tube which is measured to the last rib. You mark the location on the tube, and then you can administer an antiemetic to prevent the animal from retching as the tube goes down. You have to lubricate that tube and pass it down the esophagus to the measured point. And basically you can use just regular tap water with gravity through a funnel or a pump. And I just wanted to remind you that the gastric volume is about 10 milliliters per kilogram, so you probably don't want to put more than that volume of water in the animal. You basically you can tip the animal with its head lower than the chest to allow the fluid to flow out by gravity, and this can be repeated until the fluid comes out clear. And finally, before you remove the tube, you can always put some activated charcoal inside the stomach, and before you remove the tube, you want to kink it just to make sure that as you remove the tube from the stomach, there may be some stomach contents that will leak out as you pull out the tube. So if you're not sure whether vomiting has totally cleaned out the stomach and there is a potentially lethal exposure to something, this is something that you can also do after inducing vomiting. You can perform a gastric lavage, and I'm thinking about particular cases like iron tablets or chocolates or some human pills or some pesticides, which are very dangerous. Now, this is endoscopy and gastrotomy. Is not really mentioned in most decontamination procedures. It obviously is a most radical procedure, and it may be indicated in situations like corrosive batteries that are not going to come out of the stomach unless you go in there mechanically and remove them. Iron tablets, they tend to form big lumps of, like if it was a heavy stone. Those are also very difficult to remove from the stomach. Things that will expand and cause a foreign body obstruction, like Gorilla Glue, and some toxicants like pennies that will leak their sink slowly, and unless you go in there directly into the stomach, and pull them out, you're not going to do it any other way. One of the most common decontamination procedures is giving activated charcoal, also known as the universal antidote, because it binds most organic chemicals. It has a very small pores with a huge surface area, to the point that just 1 gram of activated charcoal has a surface area of 32,000 square feet. And if you wonder how much that is, it's about the area of a football field.
To make activated charcoal, first you'll need to turn hardwood into charcoal. Fill a large pot with 4-inch, 10-centimeter pieces of hardwood and cover it with a loose-fitting lid. Heat the pot over a fire for 3 to 6 hours until the wood has turned into charcoal. Let the charcoal cool, then rinse it with water and let it completely dry. Next, transfer it to a plastic bag and grind it into a fine powder with a hammer. Run the powder through a fine mesh strainer to remove any large pieces, then transfer it to a bowl. To activate the charcoal, pour about 1 to 2 cups, 240 to 475 milliliters of lemon juice into the bowl and stir until a paste forms. Cover the bowl and let the charcoal sit for 24 hours. Now, strain the charcoal in a coffee filter inside of a fine mesh strainer. Rinse the charcoal 3 times with distilled water to flush away all of the lemon juice. Finally, let the activated charcoal air dry, or dry it in the oven for 2 to 4 hours at 225 degrees Fahrenheit, 110 degrees Celsius. Store your activated charcoal in a canning jar with a tight lid.
This short animation kind of explain how activated charcoal can be prepared at home. Obviously, as I mentioned before, if you're past the point of inducing emesis or doing a gastric lavage because you think the toxin might have moved into the intestines, this would probably be the way to go with activated charcoal. Usually it's between 1 and 2 grams per kilogram of body weight, and you can combine it with cathartic like sorbitol, obviously if the animal has no diarrhea. And basically also mention that not all toxicants are bound to activated charcoal. I'm thinking of all the alcohols, the heavy metals, salts like nitrates or sodium chloride, for example, chlorates and acids. So don't think that activated charcoal is going to work for every single toxicant that is out. There we go. How about antidotes? When we talk about a specific toxicant throughout the course, we will see that there are really no true antidotes that will reverse all the actions of the toxic substances. And I can only think of one particular case in which the antidote protects 100% from the toxicant. And that is vitamin K, which is used obviously to treat poisonings by anticoagulant rodenticides. So even if we may think that the antidote will save the life of an animal, I can guarantee you that that's not true for most cases. Now, how do they work? Um, one way is by directly binding to the toxic chemical and preventing to reach the site of action. The classical example are chelators that are used against heavy metals, but most of the antidotes are going to work through one of these other four mechanisms of actions that we have here. One is preventing the conversion to a toxic metabolite. I guess the classic example is ethanol used to treat ethylene glycol. Another mechanism is enhancing the elimination of the toxicant. And a good example is Easter lilies in cats. For Easter lilies, the target organ are the kidneys. And by promoting diuresis with IV fluids, not only do we protect the kidneys, but we speed up the elimination of whatever toxin is in those Easter lilies, which to this point, to this day, has not been found yet. Now, many toxicants act in specific receptors or enzymes within the body. So a good example here are the inhibitors of acetylcholinesterase, which are many of the pesticides that we use. And we can give atropine to revert the stimulation of the parasympathetic branch of the peripheral nervous system. And finally, another method is restoring some normal physiological mechanism which has been disrupted. And this is the case of nitrate poisoning in ruminants. Nitrate is converted to nitrite in the rumen, and when it gets absorbed and reaches the bloodstream, it converts hemoglobin into methemoglobin, which is unable to carry oxygen. So by giving methylene blue, we reduce that oxidized methemoglobin back to normal hemoglobin. Now, let's see a couple of examples. Here we see ethylene glycol. The parent compound or parent molecule is not very toxic until it gets converted to all those metabolites, which we see here that are really toxic. And ethanol has 30 times more affinity for the enzyme alcohol dehydrogenase. So if we give ethanol, we are preventing the formation of glycoaldehyde and all the other metabolites that come after that one. And so the idea of the treatment is blocking that initial biochemical reaction and basically give the body time to eliminate the ethylene glycol intact through the urine. Now let's look at another example. Here we have Tylenol, acetaminophen. This is extremely toxic, particularly in cats, because they lack the main pathway of elimination, which is conjugation with glucuronide. So we could say that the detoxification pathways are those that bind the intact acetaminophen to either sulfate or glucuronide. Now, if it goes through the other pathway, the oxidative pathway, they get converted to very toxic reactive metabolites that are going to kill the cells. So those reactive metabolites can be removed by reacting with glutathione within the cell, which converts them into mercapturic acid derivatives, which are inactive. So basically, the antidote in this case is N-acetylcysteine, which restores the level of glutathione within the cell, so they don't become depleted, and they will basically neutralize the action of those toxic reactive metabolites. I'm going to move on the presentation, and we're going to discuss diuresis next. As you can see, it can be used to speed up the clearance or elimination of toxicants, particularly those that are water soluble and are excreted intact through the kidneys. If they require prior metabolism in the liver, pushing fluids is probably not going to be likely to help much. Isotonic fluids is what's used at 2 to 3 times maintenance rates, and we can also combine them with mannitol, which, as you probably all know, is an osmotic diuretic to be more effective, and that makes the IV fluids more effective. And as we will see, there are many toxic compounds for which diuresis is recommended. And the last one that we're going to see is intralipid therapy. This is something that is relatively new, and you will not find in all the textbooks. I said that for water-soluble toxicants, you can use diuresis. Well, for very lipid-soluble, this would be the counterpart to diuresis. As you can see here, it's a 20% emulsion of soybean oil with long-chain fatty acids, which has traditionally been used for parenteral nutrition, not to treat intoxications. It has a very long shelf life, but once you open it, it's prone to bacterial contamination, and therefore should be discarded after 24 hours. Now, we're going to see in the next slide is a short animation of the theory of lipid sink, which is supposed to be the main mechanism of action. In humans, it has been used particularly to protect the heart in cases of overdoses of local anesthetics or calcium blocking agents. And in both situations, they appear to improve the cardiac performance, and they replenish the mitochondria with ATP. There are many risks or complications that are listed here and mentioned in many references, but the truth is that most references say that it would be very rare in not even 1% of the cases to see any of these complications. So obviously the benefits are going to outweigh the risk if we have intoxications that are potentially lethal. On the left here on this animation, we have a blood vessel. You can see all the red cells that are flowing through the vessel. On the right side, we have the brain. So what happens in an intoxicated patient is that the T toxicants that we can see are within the brain. When we give this emulsion, basically we're introducing these long chain fatty acids that have hydrophobic tails and hydrophilic heads, and they're going to join together and form what looks like a little cell. So basically you have kind of a full lipid bilayer and a space inside. As you can see here, this is two-dimensional, but in reality is a three-dimensional. And basically you're creating like a separate compartment within the blood compartment, and now there is a concentration gradient, and it's going to, the toxicant is going to move out from the brain to within those vesicles, and those vesicles, once they reach the liver, they're going to be removed from the body. We have a list here of lipid-soluble substances for which we can use this therapy in case of an intoxication. As you can see, the cat on the right is experiencing what looks like tremors, a little bit of involuntary contractions of some of those muscles. This is a cat that was intoxicated with a pyrethroid. And if we look at the literature, there are many lipid-soluble compounds that against which we can use this therapy. We have pyrethrins, we have ivermectins, we have some human drugs, and the list goes on and on. Now, if you wonder whether a substance is very lipid-soluble and this therapy may work, you can look at how fat-soluble it is by searching for its log P value. P is the partition coefficient that measures how much of a substance dissolves in the water portion versus an organic solvent, which is usually octanol. So if the substance has a log P value greater than 1, it is amenable to intralipid therapy. In yellow, we see that the permethrin has a log P value of 6.5. So any cat intoxicated with this pyrethroid would benefit from this intralipid therapy. Now, this is the last slide that describes the dosages. Initially, we give a bolus of 1.5 mils per kil in 1 minute, and then continue with 0.25 mil per kg per hour for 30 to 60 minutes. It is important to use a filter to prevent fat emboli from going into the body. And with regards to redosing, if the animal is not responding, we can give additional boluses over 30 minutes every 4 to 6 hours until we reach a top of 8 mils per kil per day. And as I mentioned before, this it has traditionally been used for parenteral nutrition, so you may see that the doses are also expressed in terms of kilocalories per kilogram of body weight. Now, one thing we should take into account before redosing is to make sure that serum is not lipemic, because the risk of causing pancreatitis is higher in those circumstances. So thank you for listening. I hope this information was helpful. So until the next time, take care and bye-bye for now.